Thank you so much, sir. Moving towards our next session. Several studies have been shown that SGC Stimulator can reduce the oxidative stress. So the role of SGC Stimulator is going beyond the foundational therapy in heart failure with reduced ejection fraction. To guide us more and more about this, we have our next speaker with us, Dr. Sunil Lhila, a renowned interventional cardiologist. And to chair this particular session, I would like to invite Dr. Kumar, a renowned interventional cardiologist practicing in Kolkata, and Dr. Rajkumar Manda, one of the renowned critical care consultant practicing in Kolkata. Both the chairperson, please come with the dais and introduce our speaker. Okay, Dr. Kumar is absent, so Dr. B.P. Pandey will do the chair again. Thank you, sir.
So let's hear from my good friend Dr. Sunil Lhila, who's attached to Rabindranath Tagore Hospital, about the stimulators. So you have heard from Arindam the blocking drugs for heart failure, and let's see what the activators does. Over to you, Sunil.
Thank you, Chair. Thank you, Chair. Thank you, colleagues, friends. So let's see if there is a life beyond the guideline-directed medical therapy in heart failure with the reduced ejection fraction. The pen drive is not compatible with the speed meter. Temporary body. Just give me 1 second. So if the patient does not take care of the risk factors if he is for heart failure, then ultimately he would progress to heart failure per se, and then he is liable to get admitted in a hospital with acute decompensated heart failure, or come to a clinic of a physician for treatment of heart failure, and he receives guideline directed medical therapy. Maybe he receives the ICD, CRTDs, the other mechanical devices from time to time once indicated, and ultimately they would not have a smooth course as we expect, but they would have at different punctuations, at different punctative times, they would have dip in their course, and those are the conditions where they are known as worsening heart failure, and if not treated, they would have a bad course, because each hospital admission not only reduces ejection fraction but increases the chances of death, and these patients would ultimately progress to advanced heart failure, and they would require mechanical supportive like left ventricular assisted devices or heart transplant, or may go to a palliative stage where they are just at home receiving palliative treatment, or they enter few experimental studies with newer drugs which are not available or not to be treated, not to be used for treatment of heart failure. So this is the course of heart failure patients. Now, those dips are known as worsening heart failure when, in spite of the slides are different. So why are we concerned about worsening heart failure? Because about 80% of hospitalization for heart failures are because of worsening heart failure. 1 in 2 patients of worsening heart failure would get re-hospitalized within 1 month, and 1 in 5 patients would die within 2 years of their hospitalization. So this slide I discussed that it is a progressive condition, and so where did the idea came from that in spite of guideline-directed medical therapy, the patients are still at a risk, and that is the residual risk. It came from the DAPA heart failure in the trial where we knew that all the 4 guideline-directed medical therapies were given in one arm, and the other arm was a control arm. And in spite of getting the guideline-directed medical therapy, around 14% of the patients, that's 1 in 7 patients, would still have an event. So there the idea came that in spite of patient receiving guideline-directed medical therapy, they would not be doing well, and they would progress to heart failure, and that is what is residual heart failure. And that is what are the worsening heart failure, that progression of the symptoms and signs of the patient in spite of being on guideline-directed medical therapy. So what are the criteria which you need to define worsening heart failure? The patient should know that they are suffering from heart failure in past. They require hiked up of the IV diuretic, which could be in the hospital or it could be in the clinic, or they require urgent hospitalization. So how do we separate worsening heart failure with acute decompensated heart failure? So all worsening heart failures are acute decompensated heart failure, but all acute decompensated heart failure may not be worsening heart failure, because they may be de novo heart failure, which they would be admitted first time, and they would also be acute decompensated heart failure. So the Victoria trial included only the worsening heart failure. And these are the 4 domains of a patient who experience a worsening event, that there's worsening signs and symptoms of the patient. There's, if you don't control them, there'll be hospitalization or visit to the outpatients or ED, and they would require admissions. There'll be, ultimately they have more mortality and more re-hospitalization, and they would be pushed towards advanced heart failure, where they would require heart transplant and LVAD. Now, can we diagnose them subclinically once they are not in exactly worsening heart failure? Yes, we could, with some biomarkers, some imagings, and some devices, that the cardiomemes in the pulmonary artery, that we can diagnose once they are in the stage of worsening, or they are preclinical stage of worsening heart failure. These are some important trials. And if you see the Victoria trial with worsening heart failure, they included more severe patients rather than the other trials like the Paradigm heart failure trial, the DAPA heart failure, and the Emperor Reduced, which my previous speaker told was they were more of an outdoor setting trial. But this was Victoria trial, where the patient had an episode of worsening heart failure within last 6 months. Either they were admitted within last 6 months, or they required hiked up in the IV diuretic within last 3 months. And if you see the NT-proBNP, the average NT-proBNP in the Victoria trial was around 2800, which was around 1500 in the other trials. And if you see that 41% of the patients were in class 3 and class 4 symptoms, and the most important is around 40% of the patient had a primary event in the control arm of Victoria trial. What that means, that they were very sick patients, and even in the control arm there were 40% of event per 100 patients per year, vis-a-vis around 15% in the other trials. So how do Vericiguat works? Now, it is basically it stimulates the soluble guanylate cyclase, irrespective or independent of the nitric oxide, because we know that in heart failure conditions there is reduction in the nitric oxide levels. So the molecule Vericiguat stimulates the soluble guanylate cyclase, irrespective or independent of the nitric oxide, and this soluble guanylate cyclase ultimately increases the production of cyclic GMP in the cells, and that are the mechanisms by which the cyclic guanylate cyclase or the Vericiguat works. works. Now it also sensitizes whatever the nitric oxide is present endogenously, that also is sensitized. And what are the actions that it causes? Vasodilatations. It has anti-proliferative effect. It has got an anti-fibrotic effect and anti-inflammatory effect. So these are the effects which are seen with vericiguat, that it causes less myocardial stiffening, causes less hypertrophy, causes ventricular remodeling, and reduces fibrosis in the myocardium, increases renal blood flow and decreases renal fibrosis, and there is less vasoconstriction and improve endothelial functions in the vasculature. So the Victoria trial, the inclusion criteria, that patients were known to have a symptomatic chronic heart failure with in class 2 to class 4 ejection fraction 45 below and on guideline directed medical therapy, now had a worsening event where they required hospitalization for worsening heart failure, or required a IV diuretic, or with the elevated natriuretic peptide. Now patients who were randomized, the inpatients or the outpatient, they must meet the criteria of clinical stability. And what was clinical stability? That systolic blood pressure of more than 100, and the patients were off IV treatment for more than 24 hours before they were eligible to receive a vericiguat. Now if you see the baseline characteristic of patients in the Victoria trial, about 40% of the patients I told were in class 3 and class 4. About 60% of the patients were receiving triple therapy for heart failure, and around 60% of the patients were hospitalized for heart failure within last 3 months, and about 17% were hospitalized within last 6 months, and around 16% received IV diuretic in last 3 months and were not hospitalized. And if you see if you see the baseline medications, 90% of the patients were on beta blockers, 73% of the patients were on RASi inhibitors in the form of ACE and ARB. Sacubitril valsartan was given in around 14 to 15% of patients, and 3 standard of care medications was present in 60% of the patients. Implanted cardiodefibrillators were seen in 27% of the patient, and biventricular pacemaker was present in 14% of the patient. Now what was the result? The primary endpoint of total cardiovascular death and first hospitalization for heart failure reduced by absolute risk reduction of 4.2, with the p-value being significant 0.02, and the number needed to treat was 24. Now the data of this trial were not seen in relative risk reduction because the high number of events in the control group. So the data were represented or presented in absolute risk reduction, and the median time for follow-up in this trial was around 10.8 months. So if you see the different primary endpoint and the other secondary endpoint, the cardiovascular death, all were numerically lower, but of course the cardiovascular death and all-cause mortality, though numerically lower, but not significantly lower, but patients heart failure hospitalization, total heart failure hospitalization, and heart failure hospitalization along with all-cause mortality were significantly lower in patients who were receiving vericiguat vis-a-vis the placebo. Now, if you see the pre-specified subgroups, there were no changes. Patient receiving sacubitril or no sacubitril, the results were similar. Whatever was the baseline GFR, 30, less than 30, between 30 to 60 or above 60, the results were similar. IV diuretic within 3 months, that was around 17% of patient. Hospitalization within last 3 months, 66% of the patient, and hospitalization within last 6 months, around 17% of the patients. And in all 3 groups, sub-specified group, there were significant benefits. And if you see the NT-proBNP at baseline, it could be in the first quartile between below 1500, in the second quartile between 1500 and 2800, in the third quartile between 28 and 5300, and the fourth quartile above 5300, that all groups showed a benefit with vericiguat. Now, if coming to the adverse effect, could be the age above 75 or below 75, could be the systolic blood pressure more than 110 or less than 110. Is the patient receiving sacubitril or no sacubitril? There was no differences between any adverse effect in patients receiving vericiguat vis-a-vis placebo. The renal function also deterioration was, though numerically slightly higher in patients receiving vericiguat, but at no point of time they were significant vis-a-vis the placebo. And of course, if the GFR was less than 30 at baseline, the renal function deteriorated little bit faster. There were no changes in the sodium and potassium label with vericiguat. And so vericiguat is basically suitable for vulnerable patients because of It has got no effect, clinical effect on systolic blood pressure, renal functions in electrolytes, and the mechanism, the benefits persisted regardless of the baseline systolic blood pressure, and it occurred between a full range of GFR, anything above 15 GFR, that vericiguat was given. So these vulnerable patients who are at a risk of hypotension, who are at a risk of renal impairment, or at a risk of hyperkalemia, they all do good with vericiguat. And when is the best time to start vericiguat is at the time when you diagnosed heart failure worsening first time. So you should not wait for another event of worsening heart failure to occur before you start vericiguat. So once you diagnose that to vericiguat, the patient had one worsening heart failure on guideline directed medical therapy, that one should start vericiguat. And in the Victoria trial, 11% of the patients were started on vericiguat before discharge, that's in hospital, and the rest were started with vericiguat in the OPD. So these are two practical cases where vericiguat can be started, like a 72-year-old gentleman who had a symptomatic heart failure with reduced ejection fraction, and two previous heart failure events, diagnosed with heart failure 2 years back, and had a first heart failure hospitalization 6 months back, and now is again admitted with a second hospitalization for heart failure. He was on optimized background therapy, was in atrial fibrillation, coronary artery disease, prior myocardial infarction, and stabilized with IV diuretic. And this patient thought that he was doing good and was stable on guideline directed medical therapy till this admission, hospital admission, which really scared him, and he was really scared of the future admissions he could further see. Now another type of patients who can be started with vericiguat, or more commonly vericiguat were used, was around a 60-year-old lady with a symptomatic heart failure with reduced ejection fraction, diagnosed 8 months back, and she had a second heart failure hospitalization 3 months back. Now she is on guideline directed medical therapy, and she comes in the OPD, and the therapies are being exaggerated, the therapies are increased, or like they are optimized. So outpatients optimization of therapy of guideline directed medical therapy is an important way of doing it, but it is not easy because of the risk of hypotension, risk of dizziness, risk of falls, and risk of renal impairment if the patient's renal functions are not seen from time to time, and of course the risk of hyperkalemia. So acceptable alternative how vericiguat could fit in patients with known symptomatic chronic heart failure. If they have one worsening heart failure event, they can, which could be the vericiguat can be started irrespective of in-hospital or outpatients. It can be started with any other comorbidities or other heart failure therapies. There is no great effect on heart rate, and potassium level can be given up to a GFR anything above 15 and a systolic blood pressure more than 100. So what should we consider before starting vericiguat? That your patient should be off any IV diuretic at least 24 hours. The volume status of the patient and the diuretic therapy should be optimized. Make sure that the systolic blood pressure is more than 100 to start with, and other heart failure therapies continues with vericiguat. Vericiguat is available in 3 strengths, and the maximum desirable dose or targeted dose is 10 milligram, but we need to start with 2 milligram, and every 15 days you can hike the doses to double to 5 milligram, and then subsequently 10 milligram. And 90% of the patient in the Victoria trial, more than 90% of the patient could reach the target dose of 10 milligram, because it was easy to up titrate the dose. However, make sure that patient's systolic blood pressure is never below 90 when you are up titrating the dose, and don't use it if the patient is receiving any PDE F5 inhibitor like sildenafil for any other reasons, or you require to give another soluble guanylate cyclase stimulator for any other reasons like in pulmonary artery hypertension. So vericiguat has a distinct mechanism of action, that it restores the nitric oxide cyclic guanylate cyclase cyclic GMP pathway, which otherwise is reduced or is abnormal in patients with heart failure because less availability of nitric oxide. It significantly reduces heart failure hospitalization, cardiovascular death after a worsening heart failure event, and vericiguat had minimal effect on systolic blood pressure. There could be a drop of 1 to 2 millimeter of systolic blood pressures. The renal functions and electrolytes by and large are well preserved, and it can be used in patients with a GFR of 15 and above. So now after the RAS inhibitions, the sympathetic nervous system inhibitions, the SGLT2 and the natriuretic peptide system which are inhibited, we have a molecule which acts on a nitric oxide cyclic guanylate cyclase and soluble guanylate cyclase cyclic GMP pathway, which otherwise is impaired in patients with heart failure. And this is a molecule which stimulates, as Dr. B.P. Pandey was telling, that all other molecules are inhibitors. This is one molecule which stimulates and could be a treatment, especially in worsening heart failure. I end my talk here, and I hand it over back to the chair for the questions and answers, if any, we can take. Thank you.
Thank you, Sunil, for giving a difficult topic, a very lucid talk. Any question from the floor? You know, this molecule is considered as one of the fifth pillar. So those patients who are actually not improving on 4 foundational, this is the way, and it doesn't come with any price, basically no side effects. Arindam, yeah, your comment?
Okay. So
non-worsening heart failure.
If I could ask. Yeah. So non-worsening heart failure or a chronic symptomatic heart failure, otherwise reduced ejection fraction, we are not to use this molecule because there's no guidelines that we can use it. But for the benefit of listeners, there is one trial called the Victor trial, which is right now going on, which where vericiguat could be a fifth pillar if which has been tried to be used in patients who are non-worsening heart failure. And if it is successful, it could be the fifth pillar in treatment of guideline-directed medical therapy. But right now, on 2023, we don't have data that it can be used in non-worsening heart failure.
So, Chairperson, sir, your experience, any patient non-worsening heart failure ever used?
Yeah, we are using particularly in those patients where other foundational drugs cannot be used, particularly in the chronic renal failure or in sicker patients where BP is really on the lower side and eGFR is on the wronger side, say 28, 29, what to do. So this is one of the drug along with SGLT2 you can use, because you can't use RAS blockade, can't use MRS, so only thing left is beta blockade and a Vercuvo. So off-level, but patient do respond and they become a candidate for other molecules.
So if I further clarify Dr. B.P. Pandey's statement that patient should have a worsening event. Maybe he or she is not eligible to receive a RAS blockers because of lower blood pressure head or the GFR below 30. In those patients, I would not hold on the treatment with vericiguat. I'll start vericiguat. Maybe the patient would be ultimately eligible to receive a RAS blockers, but I would be slightly hesitant in starting vericiguat in patients who has no worsening event. So maybe patients who has a worsening event, low GFR, the GFR is on the lower side, the blood pressure head is on the lower side, that we cannot start a ARNI, I would not hold on. In fact, I have given to 2-3 patients and I have seen that ultimately those patients improves and their blood pressure improves, the renal function does not deteriorate, and then they become eligible to receive ARNI in future. But per se, I am not starting it.
As I said, definition is very loose.
Yeah.
If you are not a purist, say NT-proBNP is on the rise, it's worsening.
Slightly disappointing.
You are doubling the dose of diuretics, even oral, is worsening for me. So it's how you perceive it.
Yeah, absolutely. The ESC and the ACC, they recognized or they acknowledged the term worsening heart failure, but they did not come clear on the definition. Right now, they are including the definition what was used in Victoria trial. As Dr. Pandey said, that increasing the dose of oral diuretic or adding another diuretic to a loop diuretic could be a worsening heart failure. You could do cardiomems and you could see the pulmonary artery pressure from distant, and they are, if the pressures are increasing, maybe the patient would come 1 month down the line with worsening heart failure. If there is rise in HS tropi and there is no ischemic event, then these patients could be a future candidate. So there are subclinical criteria which has been not included, and unfortunately the ESC and the ACC, they are wise people, they may be in future including those criteria to define worsening heart failure, and then we would have an increasing indication of using this drug. That's my
thank you, Sunil. We'll close the session here. I would like to felicitate you, just hang on there.
Thank you.
Rajkumar, yeah.
And felicitation for Dr. Manna.